Bismillahirrahmanirrahim. Good afternoon, everybody, and welcome to the continuous CME, which is organized by the Oman Family Medicine Society and Dakhlya Primary Healthcare Committee. This series of CMEs aims to introduce and refresh primary healthcare givers and family physicians to the common primary healthcare topics, which are day-to-day practice. And today we are having with us Dr. Ismail Al-Abri. He is a consultant cardiac electrophysiologist at the National Heart Center. And we are going to discuss the approach to common arrhythmias for primary healthcare. He's also a visiting consultant at Star Care Hospital. So our CME, as usual, will have like chat area where we have, if you have difficulties in voice or the slides, and also you have the Q&As. You can put your questions on the Q&As, and we'll try to answer them by the end of the session. There will be also a poll in which the speaker will put some questions and ECG examples, and we'll urge you, all of you, to participate in the poll. And we wish you a very fruitful time. The presentation will take about 45 to 50 minutes. And we'll have after that some Q&As. Please be all through the time with us. And the floor is Dr. Ismail Al-Abri, and welcome to our session. And thank you to give us some of your busy time to enrich our colleagues at the primary healthcare. The talk is yours, Doctor.
Thank you, Dr. Zahir. It is a pleasure, and thank you for the kind invitation. Actually, it's again my pleasure to be with you today with your continuous medical education. And thanks also for choosing the topics to be covered, which is cardiac arrhythmia. Not very, I know, it's like not very common topics discussed in primary healthcare. So, thank you for giving us the opportunity to enlighten you about the approach to common arrhythmias in primary healthcare. Let's start with objectives for today's session. So actually, it was very difficult to, you know, I'm used to teach those arrhythmias for cardiologists and for physicians, pediatricians, you know, like the more specialized areas. So it was quite challenging to turn it to much more simpler and to a more kind of a primary healthcare setup. But you know, I know what is happening in primary healthcare. Myself, I have worked in the health centers before I started my residency, so I have a good understanding what's going on in the health centers and in primary healthcare in general, both in private and the government hospitals. I hope also that there are residents also joining our session, the FAMCO residents also, that they might be of a help to them in their upcoming exams. So today I thought we will discuss the clinical presentation of common arrhythmias. We want you to have some idea about the pathophysiology of the common arrhythmias, how do they develop, and we also will talk about what kind of arrhythmias that present to GB level. And I wanted also to enlighten you about which are benign and malignant arrhythmias, and what are the initial evaluation steps that you should start doing before you send it or send the patients to more, you know, a tertiary health care facility. And we will discuss some of the treatment options available for cardiac arrhythmias. You know, at the end of the day, those are primarily your patients, so you are the first one home to discuss even the options of treatments. Okay, some of them they will, let's say, tell you that I want to go abroad from the beginning. There are many people who like to go and find treatment abroad and then not to even try the treatment available in our health care facilities. So I'm also going to you know, give you an idea about what are we doing in the treatment of complex arrhythmias. So arrhythmias in general, it's again divided into many different, you know, classifications. Some people will divide it into non-life-threatening and life-threatening. Some, there are many different classifications. But I thought, for the purpose of simplicity, I wanted you to know that there are non-life-threatening ones and then there are life-threatening ones. So the non-life-threatening ones that we usually see is the sinus arrhythmias. It's very common in primary healthcare practice, and some of them also goes all the way for evaluation until the tertiary care, hospitals, because people fail sometimes to identify that they are benign. Sinus bradycardia, sinus tachycardias are kind of a benign, arrhythmias that they are not, probably not a word benign. The right word, as I said, is not life-threatening, but some of the time they can also take a lot of efforts from the patients and physicians to treat. SVT also, many people get panicked when they see a patient with SVT, but actually non-killer arrhythmia. There are also the premature atrial contractions, the premature ventricular contractions, and we are going to illustrate some ECGs, how to differentiate between those two. Atrial fibrillations and benign VTs are also, in general, is not a killer. But there are more serious ones, that can kill the patients. And many of the time we hear that patients collapse at, let's say, football fields, or, while running or while exercising, or die during sleep. So those are because of the ones that are life-threatening, like, for example, ventricular tachycardias and arrhythmias in patients with pre-existing cardiac disease, whether it was ischemic cardiac disease or congenital cardiac disease or valvular heart disease. So those are less benign ones. If you have a patient with pre-excited atrial fibrillation, again, this might be a killer. Ventricular fibrillation, of course, some form of the PVCs, or premature ventricular contractions that can induce, VF or VT. And of course, the last but not least, the inherited arrhythmias, which are becoming more and more common nowadays, and we are able to diagnose many of those patients recently. And so let me just first review with you the anatomy and physiology, so we can understand easily what are the arrhythmias that we are talking about. So in general, the heart, as you all remember, it has 4 chambers. For it to contract, we need the sinus node to start the rhythm for us, and then it goes to the AV node. I don't know whether you can see the mouse. Here I'm trying to. Can you see the mouse, Dr. Zahir? I don't know. Yes, and then it goes to the bundle of His, and then it divides into the left and right bundles. This is in general the basic the anatomy. Of course, the heart has a nerve supply. It's not like a muscle that has it can contract on its own, but it needs a nerve modulation, which is that's why we have tachycardias and bradycardias. And eventually you will get an ECG. You will those electrical activity will be projected by our ECG machine as an ECG. And as you remember, there is a P, QRS, and T. The P only represents the atrial kick, and then you have the AV nodal delay giving you the PR interval, and then you have the contraction of the QRS, which is the systole, and then the repolarization phase or ventricular diastole. Of course, this also receives autonomic modulation, and that can affect. So the sinus node fires, gives you, of course, the sinus, but there's also any part of the atrium can fire. That's why we have atrial tachycardia or atrial fibrillation. Not only the sinus node can fire electricity. You can have sinus tachycardia, like in this. I don't know whether it is playing with you also. Sometimes, yeah, it's playing. That you can have the sinus tachycardia. And you have, of course, the accessory pathways where they can initiate supraventricular tachycardias. So these are, as you can see here in this illustration, that the sinus node is silent now, and the heart is contracting because of the supraventricular tachycardias, and there are different forms of them. we'll go now. The last one of the common ones is the atrial flutter, where there's a rotation in the atrium itself and give you the tachycardia. So how does the general practitioner encounter arrhythmias? Okay, they either comes to you with palpitations, and you know, I've seen many when I was working in the health center, many patients coming with palpitations, and then we don't know like whether they have sinus tachycardia or something else. They just tell you that I feel my heart is racing, or I can feel, or I'm aware of my heartbeats, which is normally if we are sitting at rest, you shouldn't be aware of your heartbeats unless, like for example, you are watching a horror movie, or you know, like somebody scares you. Then you should feel. Then you should start to feel your heartbeats. But if you are not, then you shouldn't feel them, or you're not exercising. Okay, so if the patient is aware of his heartbeats, we call this palpitation, and this can be because of many reasons. Okay, and the other ones is syncope, a very common presentation also in the primary healthcare. School kids, I'm sure that always at least one of them will be brought because of syncope to the health center. Okay, chest pain and chest discomfort also might be a presentation of an arrhythmia. Okay, and it could be incidental findings, okay, due to something else. And there could be also non-specific symptoms like headache, lightheadedness, dizziness, fatigue, and there could be more serious ones like seizure, like cardiac arrest. So as you can see, it's kind of sometimes vague presentation, which makes it difficult for you to identify whether this is an arrhythmia or something else. Okay, but if you get any patients who complains of, you know, this, the one that I listed, doing an electrocardiogram is a must to at least try to identify, and we'll discuss this later. This was, for example, an incidental finding for a kid who wants to go for, you know, competitive sport. Now, I'm sure that all the kids who wants to go for competitive sport, they would be brought to the health center for screening first, and other screenings they do an 12-lead ECG. Okay, you identify that this is normal and abnormal ECG, and then you you know, advise the patient accordingly. So I wouldn't send this patient, for example, to a competitive sport. He might die during, you know, his aggressive exercise because of WBW. It's a killer when you don't treat it. Okay, so as I said, screening might be the one. Okay, so to make it interactive, I'm going to display some of the questions now. I think there is some mistake, Dr. Zahir, with the order of the ECG. So if you can project this question now. It's a 50-year-old with recurrent. No, sorry. It was supposed to be. Maybe there's a mistake with the age. Anyway, it's the same presentation.
Is it different case, doctor?
Yeah, I think there's a mistake in my projection. I'm just going to change it. Maybe you can project the first question from your side.
Okay, fine. This is the I relaunch. The first question about 16 years old. Palpitation, hemodynamically stable. What is the best approach? And I think you need to show the ECG, doctor, or the history is more detailed.
Yeah.
In the case of
no. This is only a question without ECG. Okay, can you project the question, please?
Again, doctor.
This is only a question without an ECG.
Okay, fine. Okay. I'm relaunching.
Yeah. So it's a 16-year-old with palpitation, and he's hemodynamic stable. Okay. No, this is not the first question. Anyway, I will. Let me just. I think this is the question. Yes, it was supposed to be question 2. Okay. So anyway, this is a 16-year-old girl with palpitation. Okay, and can you project the question again, Dr. Zahir? The same one. Yeah. So this is 16-year-old palpitation, hemodynamically stable. Okay, so what is the best approach for you? Okay, maybe the participant can answer the questions, and then we will discuss.
Now they're answering. I'll show the result now soon.
Yeah.
I'm getting like almost.
Yeah, you can give them like 20-30 seconds to think and look at the ECG. Yeah.
Yeah, I'm now getting like 40 responses.
Mm-hmm.
So, okay. Great. I'll just project the result. Oops. Share the result. Okay. Share the result.
So the majority have answered the answer number A, which is calm him down. So did the people I don't know whether they have seen the ECG that I projected. Okay. Is it no?
No. Can you project again?
No, it is projected now. It's actually in my. Just let me do it again, please.
Yeah. Yes.
Is it not shared now, the screen?
Not yet. Not yet, Doctor.
Okay. Just give me a second. I don't have an issue. Share screen. Yes. Okay. So this is the question actually. Sorry about that. Now it's clear, right? Now, yeah. So this is a 16-year-old girl with palpitation. Okay, so what is the best approach for her? If you see this ECG, you did an ECG for this girl and you have seen this ECG. So what do you do next?
Do I need to redo the poll?
Yeah. Yes, please.
Okay, relaunching. Please participate with us again. Now we are seeing the change on the answer.
Yeah, of course. Very good.
Voted 80%. Okay, we have 80% who voted. I think we'll end the poll.
Yeah.
Okay, we'll share the result.
Yes. So so the majority of the people have answered the right answer, which is to try the vagal maneuvers. And then thank you for identifying that this is a patient who is having what we call a narrow QRS tachycardia. And it's the most likely diagnosis for a young girl will be supraventricular tachycardia. And of course, the right thing is to try the vagal maneuver first, and then after that, if the patient does not respond, we will discuss all this later. Okay, and I think I have jumped few slides. Am I going forward or backward now? No, this is forward. Okay. Yeah. So yeah, we have reached here, I think, before we have that issue with the question. Okay. So the means of evaluation for any patient with arrhythmias or with suspected arrhythmias in a primary care is the most important thing is history. Okay. And as we have been taught that history can give you the majority of the answer most of the time. And then after that, especially in the patients, let's say, for example, patients with syncope, you will be amazed how much you can get from history. Physical examination, of course, important. If you can hear a murmur, and more importantly, you try to feel the patient pulse. Okay, and now we know that like 15% of patients or people actually who are more than 60 will get an atrial fibrillation. So if any of your patients who comes to you who is more than 60, if you feel the pulse for them and you identify that this patient has irregular pulse, then I'm sure that you can tell that this patient has atrial fibrillation if you do a 12-lead ECG, and you can start or refer him for the right type of management. Okay, 12-lead ECG is a must, and then having the ECG reading skills is also any important in a primary health care. Then of course you can do chest X-ray if you're suspecting any cardiomyopathy, any heart failure, to check whether there's any associated heart disease as well. And after that, you may refer to experts. And what we actually do in case we get a referral, that the things that we have that you don't have extra, in addition, of course, to the previous, things that you have done, is we have Holter event recorders, loop recorders, smartwatches now, electrophysiology studies, etc. So there is a lot of sophisticated, investigation panel that we do later on, but the primary healthcare diagnosis is sometimes the only one that we have. Let's say, for example, you have a patient with palpitation, and you do an ECG, and you have recorded an supraventricular tachycardia. So that is the only time that the patient had diagnosis of PE. Then when he comes to our office and he tells us that I went to the health center and then they told me that my heart rate was racing, but we don't know what type of tachycardia. So giving the patient a copy of the ECG is also very, very important, because it will tell us what type of tachycardia, and it will guide us also for the approach of his management. Okay, and anyway, so when you go through the rhythm strips and arrhythmias, that you have either patients comes to you with brady or tachycardia, and the tachycardia can be, the brady can be sinus bradycardia or something else more serious, or it can be the supraventricular tachycardia, that case that we discussed initially, or it can be wide QRS tachycardia, which is more life-threatening in majority of the time. So these are the common things that you will look for, of course. Okay, so let's first discuss the tachycardias, or the fast heartbeats. The tachycardias, okay, let's say, for example, you have a 20-year-old girl with palpitation. A very common scenario that comes to the health centers. Many young girls have anxiety, very common presentation that they come to you, that they say, I have a racing heartbeat. So it's very vital, of course, to do your exercise and do your homework and do the history, physical exam, and everything. And one of them is, of course, you will do an ECG. So ECG can tell you that this patient has sinus tachycardia or have something else in the beginning. So one thing also very important: does the patient at that time when you do an ECG have symptoms or no? So I was lucky to see this, for example, the first one, that we can see that there is a P, QRS, and a T, P, QRS, and a T, P, QRS, and a T. And so we know that this is most likely a sinus tachycardia. The patient is running a heart rate. She's 20-year-old. She's running at a heart rate of 140 years. She's sitting in your office. 140 is high. So why is she tachycardic? Is there something else that we need to find out? So even in primary healthcare, you might start doing the basic workup, like doing the thyroid function, for example. Is it the cause of her tachycardia or something else? Is she anemic? Many things that you can rule out before transfer the patients to the higher healthcare facility. So sinus tachycardia is a common one, and workup is will many of the time guide you to the reason for the sinus tachycardia. Okay, but look, for example, at the other ECG that I am projecting in the lower part of the screen, that this patient, I was lucky to see that he says that I have palpitation. I connected him to the ECG machine, and then when you can see here, if you look at this one, you also see P, QRS, and a T, P, QRS, and a T, P, QRS, and a T. Okay, so you think that there's also this patient might have sinus tachycardia, but if you look carefully, actually, you see that this patient was initially slow, and the P wave, if you look at the beginning of the strip, you see a P, QRS, and a T, and a P, and a QRS, and a T, and then suddenly he started to accelerate at double the rate that he came. He came here with a rate of, I think, 60. Now he's like here here maybe 70. It jumped to 140. So he doubled his rate without any warning, without him doing any exercise. So then I got alerted, oh no, this is probably not a sinus tachycardia. This might be something else. I didn't scare him. So what's going on? I don't know. So when I looked carefully, look at the T wave here, and P wave, the P does not look like this one. So this is a P that is inverted now. Here it was straight up, here it is inverted. So here it tells me that this is actually not a sinus tachycardia. This is something else, and this is most likely this patient has an ectopic atrial tachycardia. He needs more, kind of thorough evaluation and treatment, and he probably need to be referred in urgent basis to the cardiologist to try to treat him. So I would start my management at the health center for this patient. This is a sinus tachycardia. Most of the time it's benign. There are reasons for it. You can identify in a primary health care. But for the other one, no, this is not a sinus tachycardia. This is something else. And if you leave this patient with this ectopic tachycardia, he might present with cardiomyopathy. If you refer him as a routine referral, for example, our appointments sometimes they are at 6 months or 8 months. And you tell us that I have a patient with the sinus tachycardia, and unfortunately also we cannot see the ECGs done in the health center, so referrals does not come to us. There are no means to scan those ECGs and send it with the referral. That is something we have to work on also. Okay, so the person who received the referral will say, okay, this is sinus tachycardia, I'm going to see him after 6 months. Okay, but if you tell me no, that I have a patient with an ectopic atrial tachycardia, I'm going to see him the same day. This is kind of an urgent or emergency, you know, because this patient might go into heart failure easily. Okay. We have done this quiz already. Now there is another question here. If you can project this question, Dr. Zahir, please. And this is actually a patient presented with SVT, okay, and he received adenosine. And the illustrated effect is this one. So I can see, if you can see in this slide, that there is something happen. You and the health center tried to give this patient adenosine. You tried vagal, didn't work, so you are giving adenosine now, okay? And this what happened, okay? So what do you do next, okay? So just spend some time reading the, you know, or looking at this ECG, and then these are the answers. So you need to do what next? Give him a higher dose of adenosine, you do synchronized cardioversion, or you send him to emergency room, or you try vagal maneuver. So what would you do? Okay. I'm sorry, I have the in two different slides, the ECG and the, so I'll keep flipping between them. This is the ECG, and these are the options, okay?
Yeah. Well, I'm getting now 70% of the votes.
Yeah, we can give them some time, yeah?
Okay.
Yeah.
Okay. I'm showing the result, Doctor.
Yeah. Yeah, I can see that the majority of the people have very good understanding of how to manage the, you know, supraventricular tachycardia in the primary healthcare. So now, why did I project this ECG?
Dr. Ismail, they don't
Okay.
see the result, I think, sometimes. So I think you
Oh,
need to
so
give...
the majority of the people have answered that to give a higher dose of adenosine. That was 72%. 9% they said cardioversion, and 15% sent to emergency room, and you know, 4% say try vagal maneuvers. Okay, so in the question we said that this patient was stable, but I did not actually project this ECG for a quiz purpose. I projected for something else. I projected to tell you that when you give adenosine, you can also record an ECG. And when you send me this ECG with the patient, after that, I know what happened. I know what kind of arrhythmias that this patient had. Because what happened actually, if you see that this is a supraventricular tachycardia that gets terminated, many of the time you call the emergency room that you say the patient, I give him 3 times adenosine and did not terminate. But it's actually terminated, okay? So the tachycardia has stopped here, and then there's a, it went to, you know, PQRS, and then PQRS, so the long PR here, and then it restarted the tachycardia again. So I know what type. I know this is an AV nodal reentry tachycardia, and what type of treatment I give. So yeah, according to the protocol, of course, we can still give a higher dose of adenosine according to the you know, ACLS guidelines. And if the patient is stable, unless the patient turns to be turns to the other side of unstable side, then of course you have to synchronize cardioversion at that time. Okay. And if he is not stable, you don't send him to emergency room. No, you synchronize cardioversion. If he is stable, you still can give 3 times of adenosine. If you cannot terminate with adenosine, I agree with the answers that you should, you know, send the patient to emergency room. But most importantly, actually, is to do an ECG, 12 lead. And if you cannot do a 12 lead, at least connect him to the crash trolley where you can run a continuous rhythm strip. what you can do is in the ECG machine, there is a button called rhythm strip. Okay, so during adenosine, it will continue to print the ECG for you, and it tells you what happens, and you can send it to the to the cardiologist or electrophysiologist to tell him what happened. Okay, let's say for example, this is a 12-year-old, had a VSD closure when he was young, and then again he presented with tachycardia. People thought this is an SVT. Okay, although it was a little bit wideish QRS tachycardia, so they gave him adenosine, and with adenosine, as you can see here, if I might, I don't know whether I can zoom. Unfortunately, I cannot zoom again this picture. But if you can see that what happens in the background, there are P waves running, okay, in the background. So this patient actually has atrial flutter, okay, and the next slide, it becomes more clear. So the AV node gets blocked, okay, blocked, and the flutter will show, okay, after the adenosine. So no matter how many adenosine you will give now, it will still continue to do the same. It will block for, the half-life of adenosine is only 15 seconds. So no matter how much adenosine you give, it will still continue to do the same thing for you. It will block it for some time, and then it will continue to come back again. So this patient unfortunately received 3 times or 4 times adenosine, large doses. Then he did not convert, and then he went into hemodynamic instability after that. So they have to synchronize cardioversion, and then after cardioversion, you can see that he is now in sinus rhythm, and he has the right bundle branch block because of the previous surgery that he had. Okay, let's go to more malignant arrhythmias, which is of course most of the wide QRS tachycardias are malignant. Okay, which is the VTs. There are some forms of benign VTs, but that leave this to the cardiologist and electrophysiologist. But for you, when you see a patient with a wide QRS tachycardia, this is VT unless proven otherwise. So if the patient is stable, then the best thing is to send him to emergency room. Okay, or if you want to try cardioversion yourself, and you feel that you are confident in the primary healthcare setting, but I wouldn't recommend it because you don't know what kind of an underlying, heart disease he has. They might be having cardiomyopathy. They will go into VF. But of course, if any patient who is not stable, like and it's a shockable rhythm, then you have to do and to practice your ACLS guideline. So in general, if you have a tachycardia, how you manage? If it is a narrow QRS and the patient is stable, you can try vagal maneuvers. Okay. I recommend that you record the rhythm if you try vagal maneuver, or you can also try adenosine if that doesn't work. And please record the rhythm and send it to us during the whatever you are giving. If it doesn't work, of course, then you might the adenosine or vagal, then it might be an atrial tachycardia or flutter. Then you send it to us, who will treat it with our. We have many different medications we can use, and ablation, of course. If the patient, of course, unstable, then you have to try electrical cardioversion. If it's a wide QRS tachycardia, unstable, again, your ABCD and cardioversion. If it was irregular tachycardia, then you have to synchronize cardiovert. If the patient is stable, then you give adenosine. And then sometimes we do this in emergency room. I wouldn't recommend it in primary health care. We give adenosine to make sure that it is VT and not SVT sometimes. Okay. Now let's slow down a little bit, and we go to the bradycardia side of arrhythmias. Okay. And again, this is a common encounter in, in primary health care. You have a patient who comes to your office, you examine him for something else, and you find his heart rate is 40. Okay, so you know like what to do with this patient. You ask him, you take history, he is not symptomatic. He's an athlete, so what do? He's probably 40 because he's an athlete, he's a marathon runner. Or he might be, might be actually having something else. He might be having sinus node dysfunction. So how do you go after this? Which one of those patients you will need to refer? Again, you go back to your history. Excuse me. So if the patient is an athlete who comes to me and his heart rate is 40 and he is not complaining of anything, not symptomatic, not syncope, then I wouldn't worry about it. But if a young girl comes to me with a heart rate of 40 and she doesn't seem to be an athlete, and she gives me a history of like fatigue, or syncope, then no, I need to be more worried. Maybe it's something else. So again, history will tell you here what to do when the patient comes with a sinus bradycardia. Is it only the sinus node is slow, or it is actually sick? So what are the causes of slow heart rate? It's either sinus bradycardia, or it can be more something serious like sinus node dysfunction, the patient with slow junctional rhythm, or is it like an atrioventricular block, or sometimes premature atrial contractions in newborn, okay, or finally it might be long QT syndrome. Let me discuss with you this case, very interesting case. This is a patient whom we saw or was referred to us actually 3 years ago or 4 years ago. She's a 24-year-old. She was at that time 21 or 22-year-old, and she has a chronic fatigue. And then there was, suspicion with the primary healthcare workers, that primary healthcare doctors, that they say that there could be something serious. So why this patient has fatigue? She cannot do her daily exercise. So they decided to run well-feed ECG, which tends to be, as you can see here, you have a peak, QRST, peak, QRST, nice, everything is nice, but it is bradycardia, okay? So this patient had sinus bradycardia. But why does she have sinus bradycardia? We put her in treadmill with exercises. She goes only to a heart rate of 70. Okay, that's the maximum that she can get. So she clearly have a sinus node dysfunction. Okay, unfortunately, this patient, so of course, this patient received a pacemaker for her, a sinus node dysfunction. But I received a call 2 or 3 days ago from Sahar that her kid, who is a 5-year-old, arrested. He was complaining of an abdominal pain. They took him to the health center, and he arrested there at the health center. And they tried to resuscitate him, gave adrenaline, sent to emergency room, Sahar Hospital, but unfortunately now he's brain dead. So why did that kid arrested? We are trying to understand why a 5-year-old, who is his mother, was having a sinus node dysfunction, is arrested. Is that related to, is it as an inherited condition? Now I have 4 families with what we call an progressive conduction disease, which is an inherited disease. Okay, and unfortunately, that time when she came 4 years ago, nobody screened the family for this disease. So probably the kid has also sinus node dysfunction. He went into sinus arrest, and that's why he went into cardiac arrest. And so that's an unfortunate story that happened last 2 or 3 days ago. So so if we see those patients, if you encounter any patients with very slow heart rate, young, then we have to be careful and make sure it is not a sinus node dysfunction, which can be inherited sometimes in young people. If you see it in an 8-year-old man or woman, then it might be because of the aging process. But in young people, no, we have to be more careful. Okay. Can we project question number 4, Dr. Zahir, please? Yes, so this is a 13-year-old with exercise intolerance. Okay, so what is your diagnosis? Okay, is it first degree AV block, or is it sinus arrhythmia, or is it complete heart block? So please take your time. I'm going to give you 30 seconds to look at this ECG and tell me what is your answer. Okay, please take your time. I can see the answers are swinging in during the choices. Okay, please take your time. I think you can answer, you can like 18 voted, 19, 20%. Yeah, take your time. I'm gonna give you more time for this. This is very important.
Let's have a look. Now we got like 65 answers.
Yeah. Yeah, you have like 70% of people are voting, but still are people answering. 75. Okay. 10 more seconds.
I think now they stopped. Okay.
Yeah. Yeah.
So,
okay. So we have like almost 80% voted, and so 15% have answered that this is a first degree AV block or heart block, and 27%, sorry, 27 have answered it is second degree, which is 36%. Sinus arrhythmia, 4%, okay, and complete heart block, 45%, which is the majority, okay. I am glad that like 90% of people have detected that this is not sinus arrhythmia, okay, and the few people who have answered this is sinus arrhythmia, then you know, we have to do more work. And you know, if you can see here that in the first ECG that I showed you, that there is always a P, QRS, and a T. Okay, in this particular ECG, if you can see here that this QRS has no T wave, it has no P wave before it. Okay, and there's the P wave comes just after the QRS, and there's a T wave here. Then there's a P and a QRS and a T. Another P wave comes here in the middle, and then there's a long gap. There's a QRS, there's a P here, okay, and there's this P here. So can we have a relation between the P and the QRS, or it is dissociated? To me, it looks like it is dissociated. So you have the P and the QRSs are not related to each other, and then you have almost 2 Ps for each for one QRS. So that means this patient have complete heart block. Okay, so the right answer for this is complete heart block. But anyway, if you could diagnose that this is a you know, heart block, and this is good. Of course, this is not a first degree AV block. It's a benign arrhythmia, first degree heart block, but the complete heart block, of course, this patient will require a, you know, will require this. So what happened here? What did we do? Here we implanted a dual chamber pacemaker for this patient. Yeah, you can remove the questions, doctor, the answers from the screen. Dr. Zahir, yeah. Yeah. You can see here that we have the P, and there's a pacing spike, and then a QRS, okay, P, pacing spike, and QRS, so that this patient has been implanted dual chamber pacemaker. Now let's go to the irregular heartbeats. Hello?
Sure.
I think, did we run out of time?
Now we are almost like
45 minutes?
Yeah.
Yeah. Okay, so probably I'm going to skip some of the slides. Okay, maybe we will end in 5 minutes.
And
can we continue?
Dr. Ismail, I mean, it's there also. So we can get more sessions, I mean, in the coming days or weeks.
If you want, I am happy also. It's fine.
Please go ahead.
Yeah, you want to continue now?
Yeah, I think let's finish by after 5 minutes, then we can keep time for Q&As. But okay. Still, we have like only 6 questions, I mean, related. Yeah. I think let's go till time of 55 minutes. And then we can...
I will just go, maybe these are now less probably. Now, as you can see here, if you compare this, can you remove the question, the answer from the sharing? Shared screen, just remove the answer.
It is out now, Doctor.
Out only with me? Okay.
I can just close it from your side.
Okay, fine. So now you have the first ECG here is showing, now I'm discussing the irregular heartbeats. So many of the times you will see a patient who you examine and you find that his heartbeats are not regular. The first ECG showing clearly sinus arrhythmia only. You have a P, QRS and a T, P, QRS and a T. Second ECG to the left, you have a P, QRS, and then there's another P wave here that brings the next QRS early. We call this as premature atrial contraction. The QRSs are still the same. While here in this morphology, the QRS are wide, and we call them premature ventricular contractions. Okay, so those are different types of causes of why patients will have an abnormal or irregular heartbeats. In addition, of course, of atrial fibrillation, which is more common in elderly patients. Can we now share question number 5, please? Okay, so question is 11-year-old with syncope at school. Okay, what do you think is the cause? Okay, you have like 30 seconds to answer. Yeah, we have like 60% voted now, and I can see, I'm very glad to see that the majority, 80% of people have answered correctly. Okay, excellent, very good. 70%. Okay, you can end the vote now. Yeah. Okay, so we have like the answer number 1 is hypertrophic cardiomyopathy. There are 11%, and vasovagal is 9%, and there's 0 who answered psychosomatic disorder. Excellent. And then long QT syndrome is 80% of the answer, which is of course the right answer. This is a very bizarre and long QT. You should not miss this, because this patient is lucky now that he has only syncope. The next event might be sudden death. Okay, so you have to be careful. And just quickly, how to calculate the long QT, of course, is that you have the one of the important things in long QT is that the patient has to be bradycardic. Most of the patients, if you see him tachycardic, this is not long QT. Next thing, you calculate the beginning of the Q to the end of the T interval. We call it the Bassett formula. And you have to do it this way, okay? You have to have the sharpest angle, and then you calculate the Bassett formula, which is the QT divided by the square root of RR interval. The QT, of course, you have to calculate how many square roots, for example, here, how many squares, and then you multiply by 0.04, okay? And then also you calculate the RR interval and you multiply by 0.04, and then you divide them, and you'll get the answer, okay? This is, you can find it online, the Bassett formula, okay? And then it will tell you what this patient. Of course, this patient, I implanted an ICD for her, and after some time, as you can see, that she comes to this one, to the device clinic check, and then you can see here that again she had the same problem. She had a torsade de bois or ventricular fibrillation, and the device gave her a 36 joule, and then went to sinus rhythm. So the device saved her life. Luckily, that we got here in the right time, and we implanted here the device on the right time. Okay, so what are the treatment options for arrhythmias that we have? It's either no treatment if it is a benign arrhythmia. Okay, we have a medical therapy. And what is your role in of course, in primary healthcare? If it is a benign only sinus arrhythmia, you wouldn't treat. Okay, identify when to refer. Very important. Medical therapy, in your role in the primary healthcare is with whether you need to adjust or follow up the side effects. Okay, The other options, of course, available when we have a patient arrhythmia is electrical therapy like cardioversion, okay, device therapy, like ICD or a pacemaker, ablation therapy, anticoagulation, genetic testing, and exercise restrictions. All of those we take it in consideration on management of the management. So of course, as a GP or a primary healthcare practitioners, you have a big role, of course, a major role in diagnosis, initiation of therapy sometimes, follow-up of INR, follow-up side effects of medications, okay? And patients always comes to you first, and then you are the one who decides what to do. Okay, let me give you this last question, maybe very important. A 60-year-old man, Dr. Zahir, can you project this, please? With history of CVA in the past. Okay, he has well-controlled diabetes. He comes to your clinic. Okay, and as a part of his routine follow-up, you do this ECG. All right. And which medication list, okay, you would recommend to change? Is it diabetic medications you want to change, or hypertension medication, aspirin, or lipid-lowering drugs? Based on this ECG that you have made, so a patient, okay, comes to you, which medications that you need to change now?
Getting 60%.
Okay. Yeah, we have 60% people who have answers. I think here the diagnosis is pretty clear. And the ECG, this is an atrial fibrillation. You can continue answering. I'm just for the people who have difficulty in reading the ECG. This is an atrial fibrillation. As you can see, it's a regularly irregular rhythm. You cannot see a clear P waves. So this patient, you diagnosed him now. You did this ECG. You either identify there is an abnormality in the ECG and you have to do something about it, or you have done this ECG and you passed it as normal, which is like bad, okay? Or you have done this ECG and you identify this is an atrial fibrillation, but you didn't do anything. It's also bad, because this patient is actually having had a CVA in the past. He's hypertensive, he's diabetic. Okay, although he is controlled, so we don't need probably to change anything in his hypertension and diabetes medication. Okay, but this patient needs to be anticoagulated now. Aspirin will not protect him from another CVA. Maybe his CVA in the past was because of, undiagnosed atrial fibrillation or paroxysmal atrial fibrillation. Now he gives you the diagnosis. So for you to prevent another attack of stroke, which is a very bad disease, I cannot tell you, of course, this is many of it can be the end of his life because of the second stroke. Okay, luckily he probably have recovered from the first one. Now you have to do something. You have to anticoagulate him. So aspirin is not an anticoagulant. Aspirin is only antiplatelet. Okay, so this is a must now that you have to anticoagulate him. Okay, if you want to start yourself anticoagulation, if you are not comfortable, then you can send him to physicians or tertiary healthcare workers to start the anticoagulation. But it is you, primary healthcare practitioners, who is going to decide the fate of the patient. And your decision is based on your ECG reading skills, that you were able to diagnose him an atrial fibrillation. And second thing, the knowledge that you of course need. That's why we are here today. The knowledge that you need to know that this patient is a child class maybe probably 4 now, and he needs anticoagulation. Okay, it's a must to anticoagulate this patient. All right, so I'm going to, this is another question here. that I've put. I don't know whether you have it, Dr. Zahir, 70-year-old with atrial fibrillation.
Yeah, can we let them see the ECG, then we can put the ball so they
Yeah,
can read?
I'm projecting the ECG now and the question. Is it projected?
Yeah, it is projected.
Yeah.
ECG.
Okay, so this is 70-year-old with atrial fibrillation. We know that in the past. And he comes to you, to the health center or primary health care facility with vomiting. Yes. And this is what did you find? Now, this is a very difficult question. This is my last question, but you know, this is the distinction, what we call it always, a distinction question. Okay, you did, okay, and this you find this findings. Okay, so what are you going to do? Okay, what is to blame for him? Why is this patient vomiting? Is it he be developing renal failure? Is it medication toxicity? Is it hepatic failure? Or is it gastroenteritis? Okay. Now, we can start the answers, please. Wow, I'm glad to see that the majority are answering right. Excellent. Okay. And people are answering quickly also. Maybe they want to go. They want us to finish. Okay. But they are answering right, but quickly, which is good news also. Okay. The majority now is the right answer. Okay. Carry on. So just while you are answering, I will just explain that this ECG, this patient have a sinus beat and a PVC, sinus, PVC, and then he went into this rhythm, which we call it bidirectional ventricular tachycardia. If you look at lead 2, that one QRS is up, one QRS is down, one up, one down, one up, one down. Okay, we call it bidirectional, and this is only seen in digoxin toxicity. Okay, so this is a medication toxicity. Maybe you can stop the answers now, and then I'm glad to see that the 76% of people have answered the right answer, that this is a medication toxicity, and namely is digoxin. That's usually to be blamed for this. Now, just my last 2 or 3 slides. So what we have, more than you in the primary healthcare, of course, we have the devices. This is how I took this from one of the labs I work in. This is the pacemakers, how they were started. They were huge devices. Now they are very, very tiny and very small. And we have now the smallest one, which is the Macra, the leadless device. Okay. And of course, what we also do, we do electrophysiology studies, 3D mapping, and then we ablate the arrhythmias. It's kind of very sophisticated technology that we are using to stop those arrhythmias, especially the malignant ones. Okay, but luckily the cure rate in our lab is like 90%. So this is very good and very reassuring. So take-home messages that have, I don't know whether we call it take home, because you are at home now. You say keep in your brain or remember anyway. Okay, usually in the presentations we say take home. In the conferences. So ECG reading is a skill that needs to...
You can say keep it home.
Yeah, keep it at home, okay? keep home messages. ECG reading is a skill that needs to be maintained by continuous educations and practice. Master your BLS and advanced life support skills. Identify the seriousness of the disease. Okay, identification of the seriousness of the disease will guide you to what type of referrals you make. If you think this is a benign, or this is a non-killer that, as I discussed in the beginning, then you can, refer a routine. If you think, no, this is a serious condition, then you have to refer as soon as possible, or send to emergency room. Ask for help early, okay, better than late. Sometimes if you delay, if you try yourself to fiddle with the patient, you might cause harm than good. Treatment is available in National Heart Center to almost all types of cardiac arrhythmias, which is with a state-of-art technology. We have everything. Okay, this is a picture of our lab in the National Heart Center. We have all types of technology that are available in the world, and alhamdulillah, we are treating the majority of the arrhythmias, and we implant all kinds of devices available in the world. So that was my last slide, and thank you very much for your attention and for your participation. It was sorry for taking more time than expected, Okay, and thank you also for participating in the answering of the quiz.
Yeah. Thank you, Dr. Ismail. I think we can take initiative, Dr. Ismail, for the future about, how we can share ECGs and get it more, read by the cardiologist, and so we can also we get new innovation, on sharing ECG, discussing such cases, which sometimes we get a lot of dilemma even with cardiologists. Is it what we think, or it is a different diagnosis on this issue? So let's think on the future about this matter. And people are asking for more sessions on the ECG and arrhythmias. So we can discuss later, or if we can focus on bradys, or then on tachys, or whatever.
Yeah. I think this is we need at least, it's usually we do it a two days course, or sometimes even 3 days course for the full ECG. So this was only a taste, I would say, for the ECG, but for us to have, to master ECG, you really need to do the full courses of the ECG. Okay, and you need to do this continuously. But for you, what I see is that many people are skeptical of doing ECGs because they are afraid of reading it. Okay, so they don't want to do an ECG because they don't want to see something and then what to do.
That's a bizarre thing.
I've seen that happening even in the heart center. Why you didn't do an ECG for this patient? And the people who have problems with reading ECGs, many of them, they wouldn't do it. Okay, they'll just carry on. So I recommend that you do ECGs, even if you don't know the answer. You can ask for help. You can, if you have any doubt, you can ask for a colleague. And we are all available for help. And maybe having a system to read an ECG, of course, it requires more staffing and requirement. Now we are trying to have an artificial intelligence, programs that might help in the future. Okay, we have starting with smart watches now, that the patient can wear, and it gives you 37 diagnoses of arrhythmias only with artificial intelligence. Okay, so there's a lot of developments happening with this field. Probably in a year or two, I would think that most of it will be artificial intelligence, and you wouldn't need us. Okay.
Great, thank you. Still, I think with this session will be like an appetizer, Dr. Ismail, and then we can get main meals later on with more, inshallah. So can we go for the Q&As, Dr. Ismail?
Yeah, please, yeah.
Yeah, I think you can see the questions, Doctor.
No, where do I go? Yeah, Q&As, yeah, okay.
The first question was discussing about the SVT. I think or he'd want to discuss more about how to give adenosine. I don't know what the questions is.
Because I cannot see them actually.
The question one was please some elaborating on the maneuver. Looks like question.
Yeah, the maneuver, of course, it has to be a practical session. It's very difficult, but there are many videos that just write the right way of giving adenosine in YouTube. You will find many illustrations there actually.
Yeah.
Okay. Yeah.
I think improper technique of adenosine. Administration.
But there's that ECG that I projected where the arrhythmias has terminated. The patient, I know that he received adenosine in the proper way because the arrhythmia has stopped and the AV node was blocked because only the arrhythmias was persistent. That's why it came back. Okay, so but this is one of the clicks why people fail to terminate the SVTs with adenosine is that they're using the wrong techniques. You're right. Yes.
Unless it's considering the vagal stimulation on this issue, on the question.
Yeah, of course, there are different types of vagals. It depends on the age of the patient. Sometimes in younger ones, you can try the carotid massage. You can try the ice packs. Okay, you can try even blow maneuvers. There are different types of maneuvers, even standing on their hands sometimes. Okay, can terminate the SVT. Okay, You can have you can try for 5 minutes, all of those. If it doesn't work, then you give adenosine. Adenosine is usually a safe drug. Okay, if you give it the right dose, unless those patients who have a history of asthma, it might cause a bronchospasm. But normally in the right dose, it's usually a safe drug, and its half-life is only 15 seconds. But it is not pleasant. Okay, for the patients who are awake, you give them adenosine, their heart will stop for a few seconds. Okay, so, and then they feel that they'll start crying because they feel that they are dying. Okay, so it's not pleasant medications to try, but sometimes you have to give it. Yeah.
Great. Dr. Ahmed is asking about, unavailability of sedation in primary health care. When a shockable rhythm should be given.
So that's very important also. Sedation to me is mandatory for those patients, because giving an electrical shock to the patient is very, very painful. And I have asked the patients whom we implanted devices, for example, ICD, and tell them how did you feel? Some of them, they received the shock, inappropriate shocks. Okay, so the patient was actually fine. The device was faulty and gives him inappropriate shock or identify wrong rhythm. So they said, I felt like a horse has kicked me. Okay, so it is very painful. So sedation is mandatory. If you don't have sedation and the patient is stable and awake, it's very difficult to cardiovert. So I would advise to send him to emergency room if he's hemodynamically stable. If he's not stable, of course, he will be not conscious or subconscious. Then you have no choice. You have to shock him. Yeah.
Dr. Mukhtar asked about how much GPs can rely on normal ECGs.
So that again?
How much GPs can rely on normal ECGs at health center setting? I think in patient coming with palpitation, history of palpitation. Yeah.
So of course, palpitation is there's something called symptom rhythm correlation. So if the patient have palpitation and you do an ECG and he has palpitation that time, when you are doing an ECG, many of the times I ask of my patients to go to the health centers when they are symptomatic, because it's very difficult. Their symptoms comes every 2 months. Okay, so I tell them, go to the health center, ask them to do ECG immediately, or the nurse calculate your heart rate. So if the patient have symptoms, it is the most sensitive test. Okay, if the patient doesn't have symptoms that time, then of course you are not lucky. Or maybe many of the time they say I have symptoms. When I arrive to the health center, my symptoms have disappeared already. Then it's many of the times of no use, unless it's WPW, long QT. Those are that have manifestation all the time or abnormalities in the ECG.
Yeah, and the question from Dr. Ahmed, can we still give adenosine after giving 3 doses, 6, 6, 12, or give 6?
Yes, you can.
Yeah.
No, you can. I think it's according to I'm not sure whether it's modified recently, but I think it's 6, 6, 12. But you can give another 12 in the lab, because there we give 18 milligrams. Okay, sometimes. We can give 18 milligrams, but we have more support. That's why we are not worried if the patient goes into bronchospasm or have more side effects. Sometimes they go into atrial fibrillation because of adenosine. But we can sometimes give in 18 milligrams, but you can repeat it even 10 times. There is no problem. Okay, but the patient, as I said, it's very important that you record the rhythm. If it was an atrial tachycardia, it wouldn't stop with adenosine. Okay, if it was an atrial flutter, it would not stop with adenosine. Okay, no matter how much you give 20 milligram, 30 milligram, 30 times, it will be still the same. So having the right diagnosis is important. So I would recommend, you do an ECG during. Okay.
Yeah, and review the diagnosis also.
Yeah, and revise with them.
Yeah. And here, practical question. Sometimes what to do if a patient, 47 years, 37 heart rate, asymptomatic, not athletic, he sent it to the cardiologist and told to be normal. And the doctor and the patient is not satisfied, and the doctor is yet how the primary healthcare manage with such?
If the patient is not symptomatic, so sometimes when we see this patient, actually we put them in the treadmill. Okay, we ask them to run at the treadmill and see they are maybe sinus brady during rest, but their sinus node is well reactive. So And maybe you can do that also in the health center. You can ask him to walk around the health center and calculate his heart rate. His heart rate now, if he walks around the health center, and when he was sitting it was 37, when he comes to you it is like 70 or 80, then you know that his sinus node is healthy. Okay, so again, this is a very reassuring. But normally what we do in the tertiary healthcare, we put them in the treadmill and we do an ECG and ask them to run, and then we see whether their sinus node is healthy or no.
Okay. The question I think almost answered. Can we do synchronized cardiac version to stable patient?
Stable. I wouldn't do it, because especially in primary healthcare setting, because the patient will not be sedated. Okay, he will feel that and he will feel bad and he will remember you the rest of your life. Okay, now.
It's a good dua, I think.
Okay.
Okay, then Faisal asked about how to approach a patient with recurrent palpitations outside the clinic, but has normal ECG in the clinic.
Yes, this is very difficult. That's why now we are starting what we call smartwatch monitoring. Okay, so, and I hope that we can also distribute this to the health centers. There are smartwatches that probably it's maybe 50 riyals each that can record a 12-lead ECG, not 12, a rhythm strip, very nice rhythm strip, and the patient will send it to you by WhatsApp, for example. So when he have the symptoms, he records this ECG. Of course, before we have something called event recorder. Sometimes we have loop recorders that we implant on the patients. But now with the new technology, I think in 1 or 2 years, we will be able to do it with the smart devices.
Yeah. Then Khawla's asking about irregular heartbeats. We need to refer all 3 ECG you presented. I couldn't recall the question. You can read the question, Doctor, from Khawla?
No, I cannot. I don't see the.
Khawla asked about irregular heartbeat. Do we need to refer all 3 ECG you presented?
No. The sinus arrhythmia, we don't need to refer.
Yeah.
The sinus arrhythmias are sinus arrhythmias. They usually, especially in young people. Okay. But if the patient is symptomatic, then it's probably something else. Okay. PACs, we need to see premature atrial contraction. We need to see how much is the burden, and sometimes also in rare cases they cause cardiomyopathy, and they might also indicate an underlying heart disease. Premature ventricular contraction, also we need to do Holter for them. We need to see how much burden the patient has. Okay, and we also need to know whether this is a benign or malignant premature ventricular contraction. So I would refer all of those patients apart from, the sinus arrhythmia.
Yeah, correct. And the colleagues are asking for more sessions, and they also thank you on some of the chat and the questions. Then Dr. Faisal is asking, when the patient comes with multiple BBC, like in the routine workup, and he's asymptomatic, how many BBCs and what is the criteria to refer with?
So I would initially refer all PVC patients, okay, because we need to know what is the burden. We need to do a Holter. We see, like, for example, if they are 30 or 20%, we will ablate them. Okay, if they are like only 2 or 3%, we wouldn't do anything about it. Now ablation is easy. Our success rate in our heart center is like 95% in ablation of PVC. So it's like one-time procedure. Patient comes in morning, he goes by the end of the day. One day he do the ablation, and then that's it. Okay, he forgets about it for the rest of his life. So I would refer all PVCs for at least for Holter monitor and to check whether they are significant or no.
Because sometimes we discuss such cases with the physicians, they ask us how many in a strip. If you tell them
in a strip, you cannot tell. In a strip, sometimes, especially BVCs, they sometimes come more at night. Some of them with exercise, some of them they come at rest. Sometimes they come with the patients having his coffee. So it is not reliable. And actually, sometimes we take the patients to the lab. They have 40% burden. When we take them to the lab, they have 0. We keep them for 1 hour or 2 hours in the lab trying to find one PVC, and they don't have any PVC. So we cannot treat it. So it's very variable.
Okay. Then Dr. Mahmoud asked about bigeminis and trigeminis. management and healthcare.
So by Gemini, that means there is a PVC. If it's in by Gemini, that means it's very frequent. It's probably 50%. And those patients will, of course, require, I've just seen one case in Star Care Hospital last week. His function, he was having like 20 or 30%. His function in the echo, EF was 25%, okay? So that patient is definitely requires an urgent ablation because we have to reverse, you know, his rhythm to sinus so that his function will recover, hopefully.
Okay, then another question about the, QT interval. What are the cut values to diagnose long QT?
So it's 450 for males and 460 for females.
This
450.
This is the corrected QT or the?
Corrected QT, yes. This is according to the PASET formula, 450 to males and 460 to females.
Great. And you speak about the short QT syndrome.
Short, we haven't seen any case in Oman so far.
Okay.
We have seen one in Salalah in a patient that probably it was due to, you know, patient died eventually. He came with the, with brain problems, loss of congenital problems. Okay, so but that patient, that's the only patient we saw. We're not sure whether the death was because of short QT or something else, because he had many other comorbidities.
Yeah. Then
but we haven't seen any. Yeah.
Then the question comes about artificial intelligence. Even before the talk, I was thinking about, can we do like an apps or like a platform which help reading ECG? Do you recommend any platforms, online apps which can scan and read an ECG and give you like
I am not aware of anyone that is for free, but there are many centers in the world that gives, but it has to be through institution. Like for example, if Royal Hospital signs a contract with you know, companies, that those companies, they hire people who reads the ECG for them. Okay, but this is paid, not free services. Yeah, and it is very expensive also. The problem, even in Royal Hospital, even in cardiac center, we don't read all the ECGs. Okay, many of the ECGs, they are read by you know, sometimes by the interns, by the residents. So there is no, like, so far there is no, you know, proper you know, reading and reporting ECGs even in the heart center. So because people are busy with many you know, like they are like, I think they are doing maybe 200 ECGs per day in the Royal Hospital. So if you do 200 ECGs per day, for each one, if you give 10 minutes for reporting, or 5 to 10 minutes, then it's a lot of time.
Yeah.
Okay, and then who is authorized also to report? This was a lot of discussion. It's only registrars or consultant or electrophysiologist. So it's kind of tricky. But for screening ones, at least, yeah, you're right.
I think we can think about the artificial intelligence role here in the ECG. Yeah. Be a promising thing in the future. Thank you.
I think it's coming again.
Yeah. Brugada syndrome, do you have any facilities?
We have Brugada syndrome. We have, I think, probably 10 cases here in Oman, Brugada patients. And of course, we treat them only with ICD. We implant ICD for them. And then we diagnose them usually by ECG and by what we call a provocation test. We give them flecainide IV to see the changes in ECG. But it's quite you know, sophisticated way, you know, that you have to put the patients in CCU, give him medications, monitor his 12-lead ECG and see the changes. But this is the way how to diagnose. Okay.
One of the answers, to be added, acutocholaminergic polymorphic ventricular can cause also bidirectional VT. But in
it's called polymorphic VT. It can be bidirectional or it can be multidirectional. It causes polymorphic. We have 3 families with the CBVT in Oman so far, and we have confirmed the diagnosis. 1 in Sharqiya and 2 families in Salalah. Okay, so we have this disease. Yes, it's very rare, but we have 3 families here.
Okay, fine. And still we have like some. I think we'll get more 4 questions. Then we close. I think, Dr.
Yeah.
And let's go. He's discussing about the algorithm. About using like Brugada or Verikai in Birmingham Healthcare to differentiate between SVT and VT?
Okay, differentiation. Yeah, there are many. This one, as I told you, this requires more time and more, sessions to only. I have like a presentation only on differentiation between SVT and VT that takes around 30 minutes probably. There are many types and differentiation, but that's the most common one that people are using. Yeah.
Some of the colleagues want to discuss about the benign revascularization. It may not be always benign.
Benign revascularization syndrome.
He said it may not be always a benign by the end. It can tend to be
malignant. Yes, this is very difficult to tell, even for us. Even sometimes especially young people, you get a referral for patients with early revascularization, we call it, and you think this is a common findings, and then some of those patients will have a serious arrhythmias in the future. So it's difficult to tell. But like 90% of early revascularization are usually benign. Yes.
Great. He's about to discuss about what sedation is available in Birmingham Healthcare for the shockable rhythm.
I'm not sure. Like I don't remember when I was working in the health center.
We have only diazepams.
Yeah.
Which I don't think will be. This is the only available one.
Yeah, but then if the patient goes into respiratory arrest, you have to intubate.
You have to be ready for it also.
Yeah.
Then another question from Ahmed. If you don't have adenosine, and of course, if you have adenosine, but he's asthmatic patient, and he get an SVT,
you still give adenosine.
No, okay.
You still give adenosine, but be ready to give him like nebulization. You have nebulization of salbutamol. You know the treatments of. If he goes into bronchospasm, you have to treat that. But it's very rare. First, to go into bronchospasm after adenosine, it's reported. Okay, but you have to be ready for it. But then you have to give the patient adenosine. And as I told you, adenosine is only like 15 seconds half-life, so it gets metabolized and right in the red blood cells. So it goes away easily. And you should be able to treat your patients from his asthma. Yeah.
I think we need to get like a session on Brugada. A lot of questions about Brugada's, I mean, inheritability.
Inherited arrhythmias. Yeah, I have a talk only on inherited arrhythmias.
Yeah, I think.
But that's, I thought it's quite complicated and yeah.
Okay. And do we need still to refer patients with benign arrhythmias after it aborted in local health center in urgent case?
No. For example, if you have a patient with SVT, first presentation, you give adenosine and you do a 12-lead ECG after you abort, and there is no WBW, if there's no pre-excitation, then you don't need to. Then you don't need to refer as an urgent case. He might get the next one after 3 years. Okay. But if the patient have repeated attacks like weekly, let's say for example, or if you do an ECG and it is pre-excitation, then pre-excitation is a more serious disease. So SVT with WBW is more serious than SVT with no WBW. Okay.
Yeah, I think we get final questions. I'm trying to get more questions other than Brugada, and okay.
It's interesting why people are interested in Brugada, although we don't have many cases.
Yeah, good. I mean, names, etc. I mean, when we make syndromic names, etc., people get more interested. Yeah. But it also gets us confused. I mean, sometimes with the same syndrome have different names on this issue. I think if SVT terminated and with adenosine and unmasked arterial flutter, hemodynamically stable, which beta blockers to load in health center?
So this question has two parts. If the SVT terminated with adenosine, then it is not atrial flutter. Okay. If it does not terminate, then it could be atrial flutter. So if it terminates with adenosine, then it was not atrial flutter. Atrial flutter normally does not terminate with adenosine. If the patient has atrial flutter and he's conducting fast, then you have the option of starting him on beta blockers, calcium channel blockers. Okay. So I don't know whether you have IV verapamil, for example, in primary health care. Yeah?
No, we don't have it.
I don't think you have it. So, I don't think there is any IV preparation of the anti-arrhythmic medications in the primary health care. So sometimes even if you give him, propranolol, that might help. Okay, it's not a bad idea if the patient is stable. It will just reduce his conduction from, like, for example, if he's conducting 1-to-1 or 2-to-1, then he will go into 3-to-1, which is slower rhythm. Yeah.
And can we get a patient with different arrhythmias in the same time?
Of course you can, yeah. And there are arrhythmias that dissociate. For example, you get atrial flutter, and after some time it goes into atrial fibrillation. You might get an SVT, you give him adenosine, it terminates, and the patient goes into atrial fibrillation. Okay, so you can, you can have different type of arrhythmias.
Can we get like different ectopic sinuses? Or
You can have, usually if you have a premature ventricular contraction, then it is BVC, not PAC. They usually does not come together. It's either this or that.
Okay, interesting. Okay, Dr. Ismail, I think we kept you away from your family and from your delicious dinner, I think, waiting for you there.
Oh, no, yeah, coming up.
Inshallah. Thanks a lot, Dr. Ismail. I think we can get more session. People are eager to listen more about how to read an ECG, then how to go for the bradys and the tachys, and of course, also these sessions will also get us also more confident on reading and interpreting ECG, and also discussing with our colleague cardiologist when conveying the ECG, rhythm, etc. on this one. Hope we can get more sessions with you, Dr. Ismail. And we'd like to thank you for your time given to us in this session. And the people are asking if they can get your presentation shared with them, or it is like copyright issues, or you'd like to adjust it?
No, it's fine. I can share it with them, no problem.
Yeah. And
I'll send it as a PDF file to you. Yeah?
Okay, great. And then we can, of course, I can send it to their email also. It is with us. And the video also, there'll be a video recording. It is already recorded. Then I will send you Dr. Ismail to review before we can also, because we are getting like four also video recorded sessions. After that, we can launch it online, inshallah, Dr. Thank you, Dr. Ismail. Thank the attendees for their attendance, and hope we can get like a bit grasp on the ECGs and rhythms, and hopefully, inshallah, we get more better care for our clients and patients. And thanks a lot for attendees. Dr. Ismail, you have final message to the group?
No, just to thank them for staying for for this time. I think we crossed 1 hour and a half. That's excellent, and I wish you all the best for the care of your patients, and we are all the time available for help if needed.
Thank you, Dr. Ismail, and see you inshallah to the second sessions. Assalamu alaikum.